Hello, and welcome to Health Talk, a show where we dive into common health challenges with local experts to bring you the information that you need to live your best, healthiest life. My name is Dr. Desmar Walks, family physician and local health authority for Austin Travis County. So, I just want to say thank you for sharing that because Nikki Lillen was a dear friend, and I can just imagine the two of you on a tour of the States trying to empower the people and encourage young people to get their education. And I think that's great. And we need to still do that, right? So tell me how the practice of medicine has changed in Austin since you hung up your shield all those years ago.
Well, to compare when I first came as opposed to when I retired a year ago, it's changed tremendously. When I came to Austin in 1981, to having left California, after I finished my residency, I was chief resident. After I finished my residency, they tried to talk me into staying in Santa Barbara. And that wasn't attractive. I mean, I had a tremendous education that I couldn't have gotten anywhere else. And I was appreciative, but the community was devoid of people of color. I don't think there were 40 black families in the whole county. As a resident, I did volunteer to work at one of the Catholic hospitals in downtown Santa Barbara, where the migrants who were farming avocados. Santa Barbara has the second highest production of avocados in the United States. On the weekends, they would come down to the church, only on the weekends. And I volunteered to be a doctor for them. Mm-hmm. And they all spoke Spanish. Mm-hmm. In a lot of instances, in order for them to get confidence in me, they would question my management. They would send my plan of management to Mexico, to the witch doctor, whomever, to approve it before I could do it, which was kind of funny. But after a few months, they would rely on my recommendations after I was legitimized by the witch doctors. But I didn't want to stay in that community because there was not enough. That wasn't my purpose. So I joined the United States Public Health Service Corps, and I was stationed in Los Angeles for a couple of years, and I deliberately worked in the hood to bring up some things, but that's another story. It would take all day to talk about that experience. But ultimately, things, when I came to Austin at the time, we had to apply for membership in the Travis County Medical Society. They didn't just vote on you based on your credentials. And so I went before this August committee of rednecks and who asked me, why did you come to Austin? Right? I said, because this is my hometown and I want to get back to my people. Who told you could come? I had anticipated some obstruction to my being here. And I went off. I was like Zorro. I cut them up, down, sideways, and they let me into the Travis County Medical Society. I knew that everything I did was going to be monitored, and that was okay. I prepared for it. So, meaning that everything I did, they were going to look at it behind my back to see if I was doing things right. So after about a month, they came in, Dr. James, could you join this committee and help us with continuing education? I say, okay. Then after a few months, Dr. James, can you be over the committee? So they were learning from me, looking over my shoulder. I was, at the time, in internal medicine. We didn't have a lot of active subspecialists like critical care medicine, which was my prime interest at the time, and particularly research interest. I was interested in shock. So I did a lot of critical care medicine. I would intubate patients. I would monitor them while they were on the machine. I put in pacemakers. I did all kinds of stuff that is not allowed today by general internal medicine specialists, but at the time I had to do it. But one of the biggest things that I think that it changed was, we're going to talk about prostate cancer and its prevalence in African Americans. When I got here, the treatment of African Americans for prostate cancer was crude, beyond crude. Okay, so these men who are at higher risk because they're African American, they would, after they had been diagnosed with the disease, they would treat the underlying cause. The underlying cause of the thing that causes the continuation of prostate cancer, for instance, is testosterone. That's a male hormone. It distinguishes men from women who have estrogen, which is a female hormone. So what they did was people who had metastatic prostate cancer, black men in particular, they would give them diacylstilbestrol, which is a hormone, female hormone that can make you have female characteristics. It would make you have large breasts. And you know black men don't want no big breasts. Second, they would castrate the men because the testicles makes testosterone, which feeds the cancer. So rather than give a medicine to inhibit testosterone production, they just castrated the men. So they were both castrated and had big breasts, and they would be found in the back of the hospital, in the back wards, crying out in pain, unrelieved by morphine or whatever was available at the time. It was a cruel death. So I talked to these people about their behavior. First of all, I didn't think that it was appropriate to use these old archaic medicines with high risk and low benefit. So I thought about methodology where I could help screen myself. In addition to doing prostate-specific antigen, which is a protein that is found in the prostate, and it's particular for the prostate. It's like a protein in muscle. And if the protein is found in the blood in excess, that means that the prostate is producing too much protein for some reason, and it could be cancer. So it needs to be investigated.
And we're still currently doing PSA tests.
Yes, we are. So that part was good. And a lot of these African-American men presented in the late with already detectable cancer. So what I did was I actually tried to find some urologists who were younger and more sensitive to how to approach and treat this disease. And I talked to some pathologists who were interested in pursuing a research, which what I wanted to do was learn the Doppler procedure where I could do the biopsy myself if I felt a lump doing digital rectal exam in my office, even though I'm an intern. So I spoke with at the time, the president of the American Urological Association. He was in Carolina. So I called him and told him what my plan was. I wanted to increase screening in African Americans so we can catch it earlier and prevent all this treatment with these archaic methodologies. And I was pushed back on it. I said, why are you interested in that and you're an internist? That's none of your business. Just let them do what they do. Okay, so you asked me how it changed. Well, we have changed from not giving diacylstilbestrol and not doing castrations. We now use medicines that can affect that.
Mm-hmm. So from what you've seen in your years of practice, could you talk to us about what you think are the reasons that may be contributing to the higher incidence of cancers like colon cancer, breast cancer, and prostate cancer in Black Americans?
Well, I think it's a good question, and this question has special meaning and is specific for the KZI radio audience. There are well-established disparities in cancer incidence, that is how often it occurs, its prevalence, and its outcomes resulting from the interplay or interaction between structural, socioeconomic, social, environmental, behavior, and biological factors. Breaking it down to where you can understand it, we have less access to health systems due to lack of money for copays, lack or limited insurance coverage, education, language barriers, where you live, and environmental impact like pollution. Is it safe to exercise outdoors where you live? Do you have transportation or lack thereof, access to good nutrition? And then bad habits like drinking any amount of alcohol, smoking cigarettes, and overeating processed or junk food. These are all risks for developing the three cancers, breast cancer, prostate cancer, and colon cancer, which have higher incidence and prevalence in the United States.
So the U.S. Task Force on Preventative Medicine has guidance for how often adults should be screened for colon cancer. Can you talk to our audience and let them know what those screening recommendations are?
Yes, the United States Preventative Service Task Force recommends that men and women aged 45 to 75 be screened for colorectal cancer. The decision to be screened between 76 and 85 years of age should be individually determined. If you're older than 75, talk to your doctor or provider about screening. Now, if less than 45, with high-risk factors like inflammatory bowel disease or colitis, personal or family history of cancer, genetic syndromes like you've never heard of this, but it occurs, and I've had patients with this. Familial adenomatous polyposis. That means you have polyps from the tip of your tongue to the bottom of your rectum, and all these polyps potentially can evolve into cancer. Or hereditary non-polyposis colorectal cancer called Lynch syndrome. I have a few patients who had that as well. Colorectal cancer screening is important because it can find pre-cancer and polyps before they become cancerous and when treatment is effective.
And so when you talked earlier about what you saw when you started practice years ago, and the difference in that treatment and management, just to be clear for our audience, that's not what they can expect right now, as far as how they will be treated if they are discovered to have cancer, correct? There's a decision, mutual decision, shared decision-making that occurs now, correct?
You're right. Absolutely right. But as we're talking about colon cancer.
Any kind of cancer.
Okay. Yeah, it should be, first, speaking about prostate cancer, which I just spoke about, the incidence of prostate cancer in Black men is 70% higher than in white males. Most prostate cancers are slow-growing and they never become clinically evident. And the average age of diagnosis is about 66. Screening is very important. It's recommended for a reason. If you catch it early, then there's a chance that it won't evolve into metastasis or spread across your body, ultimately ending in debility and or death. So in prostate cancer, the United States Prevention Service Task Force recommend that men who are between the ages of 55 and 69 should make their decisions about screening, and that men age 70 and older should not be routinely screened. Now, I have problems. The other recommendation by American Urological Association was that for men under 40, if they're at high risk, meaning Black men or men who have had a family history of a disease, that they be screened between 40 and 45. My personal experience was, even before these recommendations, all Black men in my practice were screened at 45. The recommendation at that time was screen white males at 50, and then I dropped it down to 40. But that was my off-label practice, because I didn't want to wait to 45. So all my Black males, they did not necessarily get a digital rectal exam, which we can talk about later, but they all got blood tests called a prostate-specific antigen, PSA. And I stayed on it now I would do this every 2 to 4 years, sometimes longer, but if I was suspect, particularly if they had a family history, it's every year. Mm-hmm. It was just a blood test.
Mm-hmm. Can you think of any role that environment plays? I know you talked about, lack of resources, lack of insurance, not being able to pay the copay. But are there any particular environmental factors that you want our audience to know about that may be associated with the development of colon, breast, and prostate cancer?
Yeah, a lot of diseases that are particular to people of color, particularly when they occur with higher frequency than other groups. A lot of it has to do with where you live. You live near a railroad track that's with trains carrying all kinds of pollutants. If you live in near highway, with you're inhaling all the carbon monoxide, not only would precipitate asthma, but it can also be a slow stimulus for cancer development. All types of cancer, lung cancer, which we won't talk about because we don't have time, colon cancer, prostate cancer, and breast cancer. Being in an environment where there are no grocery stores. In Austin, up until about 7 years ago, I think, a lot of people were moving out to Manor, because it was more affordable. But as all these people who could afford to move out to Manor, they didn't have a food source. They had to drive to Austin to Springdale, to the H-E-B. Okay, they still don't have H-E-B in Manor. They do have a Walmart. They got sense enough to build that. But I'm just saying that, our food sources were 7-Eleven and gas stations where they sell 40 ounces, where they don't have fruits and vegetables, where they sell lottery tickets. You can't grow and be healthy off that. So environment is very, very important. And all this processed food and junk does predispose to cancer. There's no ifs, ands, and buts about it. If they're selling alcohol, any amount of alcohol, unfortunately, can particularly be cancer for it. We used to think that women could drink 2 glasses of wine and it'll be helpful for your heart, which it is. Men could drink 2 glasses of wine and women 1 glass of wine. Thought that would be helpful for your heart, red wine. But that's a misnomer. We know that any amount of wine is not good for you. Any amount of alcohol is not good for you. We used to think that you had to smoke a pack of cigarettes for 30 years to be at risk for lung cancer. But now we know that, particularly in Black people, you could smoke 5 or 10 cigarettes a day for 10 years with something about our biology that, and we don't know why, that predispose us to this disease. So I'm telling you, recommending, let's think twice about drinking alcohol and smoking cigarettes. I know it's hard, but there are definitely risk factors.
How can Black men overcome the stigma and cultural barriers that are linked to not getting that regular screening for prostate cancer that they should?
I presume you're speaking specifically about digital rectal exam. The digital rectal exam, first of all, for men who choose to be screened, the PSA or the blood test, the prostate-specific antigen, and digital rectal exam should be performed, and it should be performed every 2 to 4 years. Now, the digital rectal exam is performed when a lubricated finger is inserted to feel the shape and size of the prostate, which normally is smooth and the size of a walnut. Now, this procedure is usually rejected by most Black men due to their false pride. You don't want no finger going up your behind, right? Right. And, but it's sort of unfortunate. And therefore, a lot of men are getting screened with blood tests, but not with the digital rectal exam. Men with the PSA, normal PSA, prostate-specific antigen, which men should be getting, the normal range is between 1 and 4. If you do a blood test and it's between 1 and 3, and your digital rectal exam, if you agree to have it, is normal, you should be screened every 1 to 2 years. If a biopsy is done because you have irregularity of your prostate, that could be done in the office. The men should be reevaluated every 2 to 4 years if the biopsy is negative. But the main thing is, since most Black men are going to refuse it, DR, there's nothing you can do about that. But the PSA is more sensitive anyway.
Talk to us about family history and what role that plays, particularly in screening criteria changes, because you alluded to it a little bit earlier. You said you were screening at 40, and I know that the recommendation is to do it 10 years before a family member has had a diagnosis of a particular cancer. But talk to me about what you...
Yeah, that's particularly true in breast cancer. In prostate cancer, American men have, in general, have a 13.5% risk of being diagnosed with prostate cancer over their lifetime. And the incidence increases with age to the point where 1 out of 40 will die from it. However, the incidence of prostate cancer in black men is 70% higher than in white males. And the morbidity and mortality or death from it is much higher. I often get, I was often questioned by men who were between the ages of 70 and who were over 70 as to whether or not they should undergo a PSA, prostate-specific antigen screening, and or digital rectal. And that's when you have to have a discussion with your provider as to whether you want to really pursue that. Most of the time, provider will look at whatever the end age is, like 70, when we don't think it'll benefit you. That most men will outlive that. And they'll predict that if you can live at least 10 years beyond 70, then we might be more aggressive in treating you. But if you are over 70, you have heart conditions, kidney conditions, on dialysis, whatever, then it may not be feasible to do a screen after 70.
Mm-hmm. And associated with family history as well.
Yeah, family history, if you look at diseases in general and people who die from diseases in general, about 20% of all deaths from diseases are genetically related. Mm-hmm. Okay? 20%, 20 out of 100 deaths are from genetic diseases that are genetic. If they're genetic, there's nothing you can do about it. You can't crawl back. You can't, that's for a different mama. Mm-hmm. It is what it is. But most importantly, I think what you're asking, 60% will die or suffer from diseases that are brought on by their lifestyle, the way they live. Mm-hmm. So potentially that's reversible, right?
That and the fact that if we catch it early, it may be curable as well. So.
Yeah, if you do the screening mm-hmm. and you catch it early, whatever cancer is, regardless of whether you're genetically predisposed, environmentally predisposed, ethnically predisposed, mm-hmm. if you catch it early, and that's the whole key, I think the point you're making, screening is the key. Don't wait.
And we know that a lot of people may be behind on screening because we've just come through a pandemic, and that may have been something that was lower on their list. But I'm glad that you were here with us today to talk about this very, very important issue. I want to just talk about what you think community leaders and healthcare providers can do to improve cancer awareness and prevention in Black neighborhoods.
Well, healthcare providers, particularly who have a healthcare population that's weighed toward minorities, Black and Browns, American Indians, Native Alaskans, Pacific Islanders, Asian. Mm-hmm. I think if you have the time, you should ask to appear on the Health Talk Show on the KZI. Mm-hmm. Seriously, when I was coming up, we used to have all kinds of things, particularly through the church, all kinds of screening and patient educational forums to try to appeal and educate our people to step in the arena, to be screened, to be treated, to have regular checkups. And that was very hard. A lot of them were not successful. We had talks. The most successful ones were when we did talks of patient education and prevention in churches. If I could convince the pastor that Jesus is okay, and then I would incorporate the Austin Public Health. I would get the pharmaceutical industry, have them pay for everything, pay for meals, would feed the people. Like if we were giving a talk on diabetes, then we'll actually have a dinner with diets cooked to reflect diets that are within their culture modem, like soul food, but absence the pork and a lot of the fat stuff, and the sugar, and the butter and all that stuff, that the food can be tasteful. But they have to listen to the talk first. And then we show them how to give themselves insulin, how to prepare and all that stuff, how to watch their feet for lesions and that sort of stuff. It was very, very instrumental, I think, and informative, and it causes change in lifestyle of those people. And those people who adapted to it, I think they lived longer and better. No doubt about it. There are, when we had like big shows, like I have a circus almost. I got some people to donate a circus. We set it up at one of the middle schools, and everything was free. Everything was free. Anything you can think of. We had all these booths with Austin Public Health giving education about anything that was disease-oriented. People wouldn't come because it was free. And it was, it's like I don't go to a circus or carnival without paying for it. But we had to find out and figure out how. So you had to be motivated. We have a lot of smart, motivated, empathetic people of color with Austin Black Physician Association. I am so proud of these people. I mean, when I came here, I was the first. And now we have over 100 smart, dedicated, committed. It just brings a smile on my face every time I see them. I got a hug and kiss. So I feel very comfortable given that we have these people of color that what I kind of started 100 years ago will persist. I'm convinced there won't be no letdown. And one of the commitments of the Austin Black Physician Association is to recruit students of color, help them financially to study for the entrance exam to medical school, support them with experience about what medicine is about by being a mentor, and let them. I used to have students follow me for not just a day or a week, but for years. I had one who would follow me for 2 years. She'd come in once a month. Any rate, so yeah, I feel confident that we are going to continue to improve the longevity, decrease morbidity, sickness, increase longevity, length of life in our people of color, because we have so many dedicated people.
Thank you. Thank you, Dr. James. And that's all the time we have for today's episode of Health Talk. Thank you so much for being with us today to talk about this important topic, cancer screening and prevention. And don't forget that we have a survey on KAZI's website and on KAZI's Facebook page where you can tell us the topics that you want to hear about. We want to know what resonates with you, so please share your feedback. That's all the time we have for today's episode of Health Talk. Thank you to KAZI 88.7 and to St. David's Foundation for their support of this program. Until next time, take care of yourselves and each other. This is Dr. Desmore Walks signing off. Be well.